Today we're going to talk about ultrasound in big red. When is big too big? This is Colleen Campbell. I'm a professor of emergency medicine and part of the ultrasound team here at UCSD. Our goals and objectives of this lecture are to know the indications of ultrasound for the abdominal aorta, to identify the anatomy of the abdominal aorta, to understand the techniques to visualize the entire aorta to the bifurcation, to understand characteristics of abdominal aortic aneurysms and aortic dissections, and to identify limitations of ultrasound in diagnosis of aortic pathology. I have no conflict of interest and there is no sponsorship for this lecture. So the anatomy of the aorta, mostly we're going to talk about the abdominal aorta, but we will peek upon the ascending aorta and the arch of the aorta as well. So first of all, what is an aneurysm? Any aorta over 3 centimeters or greater than 1.5 times what is expected for a person is considered an aneurysm. The average size of an infrarenal aorta in people greater than 50 years old is 1.7 centimeters for men and 1.5 centimeters in women. For the common iliac artery diameter, we expect 1.4 to 1.5 centimeters in men as average and 1.2 centimeters in women. 90% of our aneurysms are fusiform. They are by far the most common type, and you can see the picture on the right depicting that. Saccular are much less common, and that is a focal dilation of the aorta. Abdominal aortic aneurysm is still the 13th leading cause of death in the United States. Risk factors include age greater than 60 years old, family history of aneurysm with a first-degree relative having a 12 to 19% incidence. Smoking and hypertension also increase the risk. Aneurysms are present in 2 to 5% of patients older than 65 years old, and 15,000 patients die from a ruptured abdominal aortic aneurysm annually in the US still. Our indications for abdominal ultrasound to evaluate the aorta include a pulsatile abdominal mass, diminished peripheral pulses or evident vascular compromise of the extremities would indicate a dissection, abdominal pain, abdominal bruit, and part of the undifferentiated hypotension exam, which Rose first described the undifferentiated hypotension ultrasound protocol in July of 2001. It's recommended in this exam in conjunction with cardiac and fast exam, IVC, and pleura as part of the RUSH exam. So ultrasound of the aorta was historically one of the very first uses of emergency ultrasound. We had real-time ultrasound available at the bedside in the early 1980s, and it was first described in the Annals of Emergency Medicine in 1986 by George Sternbach. This is a depiction of the first ultrasound machine, which was developed in 1950, and you can see it was big and clunky, but it did have a finish in polished oak, which you will not see anymore. The first studies involving emergency ultrasound and the aorta, Yaley did an ED sonography by emergency physicians in 1989 and showed a very good sensitivity and specificity of this exam. Blavis also did a study on the frequency of incomplete abdominal aortic visualization and found that a full 25% were not visualized in totality, and 4 out of 207 they couldn't find the aorta at all, and yet they still didn't miss any aneurysms. Tayal did a prospective study of accuracy and outcome of emergency ultrasound for abdominal aortic aneurysms over 2 years, and that was published in 2003 in Academic Emergency Medicine. What Tayal found was a sensitivity of 100% a specificity of 95% with a positive predictive value of 93% and a negative predictive value, which is very important here, of 100%. So how do we do this exam that has such great sensitivity and specificity? We start with a low frequency curved array or phased array probe at 2.5 to 3.5 megahertz and start with a maximal depth around 20 centimeters. You hold the probe perpendicular to the skin in the midline with the marker dot to the right and apply a firm pressure to the abdomen. The left lobe of the liver can be used as an acoustic window. And remember that 95% of aneurysms are infrarenal, so you must scan the entire abdominal aorta down to the bifurcation. For the technique, the entire aorta must be visualized from takeoff of the celiac to the SMA to the iliac bifurcation in transverse and long planes. The biggest trick to the aorta is to get rid of bowel gas. Gentle pressure on the transducer and rocking the probe side to side are effective measures. You must keep this pressure up during your entire examination or the bowel gas will pop right back into your view. You want to orient your probe perpendicular to the aorta to avoid getting an oblique measurement. And you're going to go from the xiphoid to the umbilicus, and you're going to aim inferior at the level of the xiphoid until the spine is seen. Some tricks that you can use include having the patient take a deep breath, which lowers the diaphragm, and the liver can be used as an acoustic window. Additionally, you can place the patient in left lateral decubitus while viewing the aorta from the right anterior axillary line, intercostal, and you will see the aorta deep to the inferior vena cava. For the distal aorta, you know that it's going to bifurcate somewhere around the umbilicus, so you can put it just left of the periumbilical region, and sometimes this helps get rid of bowel gas. For the ascending aorta, you can use the aortic arch view. You can also use the cardiac peristernal or suprasternal views. And this is an example of the backup view of the aorta. So you are in a mid-axillary view, and and your marker dot is pointing up, and this is what you're going to see. You're going to see diaphragm, inferior vena cava, hepatic veins, and then the aorta has the thicker walls and it's deeper to the inferior vena cava. So this is a great view to use if you have a lot of bowel gas or midline hernia in a patient. And here again, we see the liver, we see the IVC giving up the hepatic veins, which divide the liver into its anatomic lobes. We see the diaphragm here. We see the aorta deep to the inferior vena cava. And we're moving from superior to inferior in this view. Things to be aware of. Mostly you need to be aware of bowel gas, especially the transverse colon. And the big thing to do about this is apply pressure in the abdomen. Small aneurysms may still rupture, and one good thing to do is put color flow on any area that you suspect and see if there's any extravasation in the area. Remember that a negative FAST exam doesn't exclude retroperitoneal rupture. And remember to visualize the entire aorta to detect any possible saccular aneurysms. Sometimes large periaortic lymph nodes may obstruct your view. Usually these are in lymphoma patients, tuberculosis patients, or HIV patients. So for an abdominal aortic aneurysm like the one we see here, the physical exam sensitivity is poor. For a 3 to 4 centimeter aneurysm, we can detect maybe 29% of them. For a big aneurysm, we'll still miss about 25% of them. Ultrasound, on the other hand, has a sensitivity of 100% and a specificity of 96%. If the aneurysm is more than 5.5 centimeters, usually they're going to treat this aneurysm relatively promptly. Otherwise, if the aneurysm grows more than 0.6 to 0.8 centimeters per year, this also will require definitive treatment. Physical exam, again, I've never seen a patient with a visible AAA. I doubt you will either. And now let's talk about the aortic anatomy a little bit more. We know that it lies to the left of the inferior vena cava, and it enters the abdomen anterior to the 12th dorsal vertebrae. It is superior and to the left of the gastroesophageal junction. It bifurcates at L4 into the common iliac arteries, which is just above or about the level of the umbilicus. The aortic root is best seen in a peristernal long axis view. And you can see the aortic root in a peristernal short axis view at the level of the valve as well. The supraclavicular view, though, may give you a better view of the aortic arch. Here's an example of a peristernal long axis view, and you can see the aortic valve above the left atrium in this view. And generally, the left atrium and the aortic outflow tract should be about the same size. This is an example of what a peristernal long axis view looks like. Here is your left atrium. This is your left ventricle. Here is your aortic valve and your aortic outflow tract. And again, this should definitely be less than 4 centimeters, and they should, just eyeballing it, be about the same size as a left atrium. Here is a short axis view of the aortic root. We can see the Mercedes-Benz sign at the aortic root. Above that, we see the right ventricle, the right atrium, and the left atrium here below the aortic root. The suprasternal view, we can put our marker dot to the patient's right, and what we'll see is the aortic arch giving off the right brachiocephalic trunk, the left common carotid artery, and the left subclavian artery. Deep to the arch, we oftentimes see the right pulmonary artery and sometimes see the left atrium, and you really have to angle into the chest to see that. This is an example of a suprasternal view. Usually these views are very difficult to get, and we don't often get a great picture. This is an example of an aortic arch giving off the right brachiocephalic trunk, and then the left common carotid, and the left subclavian would be coming out right here. So this is the descending aorta, and this is the ascending aorta. And you can see here that we don't see the right pulmonary artery too well in here. It may be somewhere in here. Here's another example, a suprasternal notch view. This is the aortic arch. This is the right brachiocephalic trunk. The left common carotid and the left subclave comes off here. Again, the right pulmonary artery would be somewhere in here. So, pathophysiology of an aneurysm. We have decreased elastin and collagen in the aortic wall with age. When we look at the aortic wall, we see that the tunica intima is most brightly echogenic, and it's the innermost layer of the aorta. The middle layer is relatively echo-free, and the tunica adventitia is outermost, and it's moderately echogenic. If we look at the flow pattern of the aorta, and this is a great thing to do if you're not sure if you're looking at the aorta or the inferior vena cava, use Doppler and look for the high resistance flow pattern of a normal aorta. You will have a large anterograde flow during systole and low flow during diastole. Retrograde flow will increase in the distal aorta, and blood flow in the branches of the aorta is relatively low flow. So the difference between the aorta and IVC, and it's quite common to get confused early on, but if you look at the aorta, it will have thick walls versus the IVC, if you push hard enough, you can actually compress it with your probe. The aorta will be directly above the vertebral body and on the left side of the abdomen and will look very round. The IVC may not be exactly round, and it will be just to the right of the spine anteriorly. There is no respiratory collapse in the aorta versus in the IVC, you will see variation with a sniff test. So here you can see the aorta is very round, whereas the IVC is almost a diamond shaped here. You can see the aorta is directly above the spine shadow, and the IVC is to the right of that. Here's an example of the sniff test in an inferior vena cava. You can see it collapses quite a bit when this person is sniffing. So that's a sniff test of the inferior vena cava. Let's talk about branches of the aorta. The celiac artery is the first abdominal branch, and it bifurcates relatively quickly into the hepatic and splenic arteries within 2 or 3 centimeters. The splenic artery supplies the spleen, the pancreas, and the left side of the greater curvature of the stomach. The hepatic artery branches into the common hepatic artery and the gastroduodenal artery. The left gastric artery is another branch of the celiac, but it runs immediately superior, so it is rarely seen. And this is a depiction of what the celiac artery looks like. So it's branching off above the pancreas. And this is the celiac artery with the seagull sign. And the seagull sign is made up of the common hepatic artery coming to meet the splenic artery above the aorta. And so that's why it's called the seagull sign. Here's another example of the celiac artery. You can see here the common hepatic coming and meeting the splenic artery, and it forms a seagull shape. Thus, it's called the seagull sign. This is another example of the celiac artery, and this time the celiac branches are very tiny here and you can barely see it. So you can see, just like everything else in the anatomy, some celiac arteries are very small and others are quite ample. Here's one more example of a very small celiac artery. You see the branches coming together right here to form the celiac artery. And finally, this is one more example of a large celiac artery. You can see here the branches of the celiac right here. So the superior mesenteric artery is the next branch, and actually the easiest branch of the aorta to find. The superior mesenteric artery covers the small intestine and ascending colon and part of the transverse colon. It is posterior to the pancreas, and this is an important relationship to remember, because if you see a pancreatic mass, you should be in the area of the SMA. Its branches are the inferior, anterior, and posterior pancreatico-duodenal arteries. The renal arteries branch just below the SMA from the aorta, and it's just posterior to the IVC, and they go to the kidney. The right renal artery in long plane is posterior to the IVC, and I'll show you some examples of these. So here, but this is the SMA, and this is usually the first artery that you're going to see, and then you're going to fan superior to look at the celiac artery. So what else is here? This is the inferior vena cava. This is the portal confluence, and that's going to come up and over to meet the splenic vein over here. Again, spine shadow, aorta, SMA. And here we stop the video so you can see exactly what you're looking at. Spine shadow, aorta will be directly above it, and directly above that will be the superior mesenteric artery. Now, this is a stopped view of what we would see if we really slow things down. So you get spine shadow, you get aorta, and the inferior vena cava actually gives off the left renal vein in between the SMA and the aorta. The aorta may also give off the right renal artery in that same area. The right renal artery will be anterior to the left renal vein. So you'll see these branches happen in quick succession right around the area of the superior mesenteric artery. The portal confluence will come up and over to meet the splenic vein just over the SMA. If you go in long view, you'll see the SMA, you'll see the celiac artery go, it looks almost straight up, and then the SMA will be long and course just anterior to the abdominal aorta. And this is an example of what it looks like. Here is aorta, right here, celiac right there, SMA right here. This again is someone moving long on the aorta, and one of the relationships that you see here is as the aorta goes from head to foot, the aorta becomes more anterior or shallower in the abdomen. So as we go down the aorta, we will probably decrease our depth to get rid of any unwanted depth beyond the spine shadow. This is an example of what the aorta looks like at bifurcation in long axis view. So again, this is head to foot, this is aorta, and this is the bifurcation right here. This is short axis view, so now we're transverse in the abdomen, and what we see is aorta, common iliac, and we see the bifurcation, and now we know that there is no aneurysm. We have gone distal enough to look at the aorta. So what is wrong with this picture? Number one, that measurement on the bottom is a little bit scary. It's 7.58 centimeters, but more importantly, this measurement is inaccurate. We really want to measure it from outer wall to outer wall, and a lot of times clot will fill up 50% of the aorta on these aneurysms, so that's why it's extra important to actually get from outer wall to outer wall. Let's go over some cases now. This is the first case I had. This is back when we only had still pieces of paper that we could have for aneurysms. And this was a 68-year-old male with right groin pain. And this is his right femoral artery. And you can tell that it was big. It was several centimeters big. And it was very tender. And it seemed kind of pulsatile to me. So this guy had increasing right groin pain for the past week. He had a history of a right femoral artery aneurysm repair in the past, but his pain now was associated with walking. And I saw this, a 3 by 2.5 centimeter aneurysm in the right femoral artery. So the reason why I bring this up is this guy needed definitive treatment, but if ever you see an aneurysm elsewhere, this is a huge risk factor for an abdominal aortic aneurysm. So if somebody has a popliteal aneurysm, 62% of them also have an abdominal aortic aneurysm. Femoral artery aneurysm, 85% associated with a AAA. And the risk of rupture is again related to size. So 5.5 to 6 centimeters is a 9% rupture per year rate. 6 to 6.9 is 10% per year. And if they get up to 7 centimeters, 1/3 will rupture per year. That is a very restricted lifespan, and they really need to get those fixed. This is case 2, a 68-year-old male with altered mental status. I saw him in the old Thornton Hospital. This patient was brought in by his son. He was found down in his own urine and ensenada, and he was confused. He had a history of smoking and drinking, and he was a retired Coast Guard. His vital signs when he arrived weren't terrible. His blood pressure was 100/62. His heart rate was 97. His respiratory rate was 20. His oxygen was 100%. And on physical exam, he seemed to have an enlarged liver. He was mildly tender in his epigastric region and his liver, but no clear masses. So I decided to pull out my trusty old-time ultrasound, which you can tell our images are so much better. And this is a good example of what I mean when a lot of times when you have an aneurysm, almost half of the aorta will be filled with clot like this one. And so you can see that this is a huge aneurysm, 6.46 centimeters. And so this is where getting this scanned as well. So we did a transverse and a long image here. And this is another example, a live image, same thing. Right above the spine shadow, we see a giant aortic aneurysm, which I would measure from here to here. I would also put color flow on and see if there was any active extravasation out of this. So this guy, actually, his outcome, I scanned his head, I scanned his belly, and what we diagnosed him with was an 8-centimeter lung mass with cerebellar metastasis. The patient had mild abdominal pain on physical exam. However, when I called surgery about his aneurysm, they were like, this guy has bigger issues with the cerebellar metastasis. We don't think he needs an operation right now. So this is the one case in which he had more life-threatening diagnoses this day. Case 3 is also a 68-year-old male. He presented to the ER with a chief complaint of severe abdominal pain and dizziness of sudden onset. He had a history of hypertension and diabetes and also was a smoker. He didn't look quite as stable. His blood pressure was 80/34. His heart rate was 124. His respiratory rate was 20. And his SAT was 93%. This is his aorta. He had an ED fast exam. He had fluids and blood given right away and a stat surgery consult. They wanted a formal ultrasound at the bedside, and again we see that there's clot, significant clot in this aneurysm. They put flow on the aneurysm and they see active extravasation outside of this aorta, which was a major problem, and that got vascular surgery's attention in a big way. This patient was brought to the OR. However, he decompensated and died in surgery. And 89% of patients die after rupture prior to reaching the hospital. Even of the people who reach the hospital, like this guy, a lot of them die. So it's a very bad thing to happen. This is another 67-year-old male, came in with severe abdominal pain. And again, you see this aorta is a large amount of clot here, and I would measure from outer wall to outer wall here. And so this got our attention right away. He went straight to the OR and he survived to discharge. And I put this case in so you don't think we are completely incompetent here at UCSD in our management of AAA, because the other cases aren't quite as good. This is an example of a guy who survived his aneurysm, because this is an endovascular graft here. So all of this is aortic aneurysm, but this is the functional part of his aorta right here. Next case is a younger guy, a 57-year-old male with chest pain and severe right leg pain. His physical exam showed a blood pressure of 90/45. His heart rate was 112. Respiratory rate was 18 and SAT was 95%. He had a diminished pulse on his right femoral artery, and surgery was called on the basis of the ED ultrasound. They wanted to get a CT before they took him to the OR for surgical planning, and the CT was done when the patient was stabilized. So this guy has a widened mediastinum. He has a diminished pulse on the right femoral artery. So whenever we see that, we think dissection. And sure enough, that's what we saw on our bedside ultrasound. You can see the dissection. We actually saw it go up in the carotid. We saw it in the abdominal aortic area as well. This is a live image of a dissection. Sometimes all you see is a little tiny flap, like this. The CT confirmed our diagnosis of dissection. The patient was brought to the OR and died in surgery. These are bad cases. And this is an example of what a dissection looks like on CAT scan. You will have a true lumen with blood flow and a false lumen without. This guy actually seemed okay when he came in. He was a 58-year-old male, and he came in with facial swelling. The patient had a brief episode of mild chest pain 1 week before, which he didn't even remember until I asked him about it specifically many times. He said he had no chest pain currently or shortness of breath. He had no abdominal pain. His vital signs showed hypertension. His blood pressure was at 180/98. His pulse was 92. His respiratory rate was 18. And his oxygen saturation was 95%. His temperature was normal. He had a history of hypertension and smoking, and he lived on a boat. And this is what he looked like. His facial swelling was diffuse. He had swelling in bilateral arms, and he had a plethoric-looking chest. I felt all of his pulses, and his radial arteries were present and diminished in his right wrist compared to his left. This alerted me to some sort of badness, and I'm not sure what you thought of here, but there's something you should think of when you see this kind of look in a patient, and that's SVC syndrome. However, when I felt the decreased pulse in the wrist, that didn't really make sense to me as to why he would have SVC syndrome and a diminished pulse in the right wrist. So I got out my trusty ultrasound, and this is what I saw. It looked to me like a pretty clear dissection in the aorta, definitely at the level of the SMA here. This is a nice example of the left renal vein going in between SMA and aorta as well. This is again another example of how subtle dissections may be. So I thought maybe I need to put in a central line in this guy if I'm really worried he dissected. So I went to put in an IJ, and what I saw was a dissection in the right carotid artery as well. And you can see that labeled here. This got my attention because he seemed so jolly and stable, but I sent him to CT right away, and it did show a dissection and expansion of this dissection causing occlusion of the superior vena cava, which accounted for his SVC syndrome. This patient remained symptom-free in the ED. However, he underwent surgery and he never woke up. So, very sad case, very scary diagnosis. The next case is not any more uplifting, but he was a 60-year-old male transferred for arterial occlusion of his left leg from a desert hospital. He was transferred on a heparin drip for 7 hours. He was the first patient I saw when I came in at 10, and I didn't hear about him initially. So another attending had heard about this transfer. The patient reported a history of a DVT and a history of smoking. He had had no medical care in 10 years. His blood pressure was 180/97. His heart rate was 125. His respiratory rate was 18, and his SAT was 98%. When I talked to this guy, when he hit the door, he looked really bad and very, very sick. And the arterial occlusions I had seen in the past didn't look so unstable. This patient, when I asked him, said, you know what, a chest pain woke me up from sleep about 4 a.m. And so I put the ultrasound on his leg first to see what kind of flow it had. And it indeed didn't look like it had a whole lot of flow here. And that femoral artery looked pretty generous in size. And you can see just a little middle area here that maybe could have flow, but I didn't see it here. I put it on here again to look for flow, and occasionally I would see like a little flicker of flow going through the middle. So then the next thing I did is I got a couple stills, and it almost looked like there was clot in everything. At the right carotid artery, it looked like it was all clotted off up top. You can see the vein above it, and then the carotid artery, and the carotid artery just looked filled with sludge, basically. The left femoral artery occasionally looked like it had flow, but the leg was cold. Again, this is the right carotid artery. And once I saw that the carotid artery was affected and noticed that the patient was very uncomfortable, he had diminished pulses on the right radial artery and the left femoral artery. And at that point, I was very suspicious he had a dissection. I sort of weighed my options and kept the heparin drip on while he went to CT, thinking that he had already been on it for 7 hours, so what was another 10 or 15 minutes? And by the time he got back from the CT, he started coding. He was noted to have a Sanford type A dissection. He coded for quite a while in the ED and never made it to the OR. This case is different. This was a younger guy who was noticed to have a widened mediastinum in jail when he was getting a TB check, so they sent him in for further evaluation. And the same guy, these are the views of his aorta. He had a giant aorta, and it looked like he had a clear dissection in his aorta. He was a schizophrenic jail guy, and here you can see the dissection flapping. Here again, you can see it flapping with the true lumen and the false lumen. And here is a peristernal long view of his aorta. He had a big aortic root. It was more than 4 centimeters, and you can kind of see that flap in there. So this guy, because he was a jail guy and he had a whole lot of tattoos, he seemed fine the entire time with his dissection. He went back to jail in stable condition because he refused all treatment. Psychiatry evaluated him and determined him to be competent to refuse to care, so he went back to jail with his dissection, and he seemed to do just fine. And the reason why I bring that up is if you have enough tattoos, you will survive even dissection. But for the general population, it's a very bad disease. The incidence is most common in the 6th to 7th decade. The risk factors are hypertension, connective tissue disorders, aortic dilation, cocaine use, and pregnancy. The mortality rate is extremely high. It's 1% per hour after the onset of symptoms. Oftentimes, we see this complicated by hydronephrosis, which is caused by ureter compression or retroperitoneal hematoma expansion. There may be hemoperitoneum caused by intraperitoneal rupture, so you can get Gray-Turner sign or colon sign. So finally, I'm going to put in a plug for the vegetarian diet because a man is as old as his arteries. So I would say go vegetarian and avoid the aortic aneurysm and dissection.